So we have today that is the atopic dermatitis. See, the atopic dermatitis. See, somebody also asked me what is the atopy, that we will also discuss. Say atopic dermatitis, we having this, we have the chronic conditions. So it is the chronic conditions, like we have the relapsing, if any relapsing is there, or what is the relapse? The inflammatory skin disease. It is the chronic relapsing inflammatory skin disease. See, it is, we have eczema. Eczema is what? There is like any reactions pattern of the skins secondary to the like endogenous or maybe any exogenous stimuli. So we atopy, we consider it as the endogenous eczema. The endogenous eczema. What is eczema? I told you that if any reaction pattern, if any reaction pattern of the skins, if any reaction pattern of skin, so that is known what? That is known as the eczema, and it will be secondary to like endogenous or the exogenous stimuli. Endogenous, like if any, like it can be due to any drugs, any reactions or the any reactions that causing any pattern on the skins, that we called is the eczema. And remember, this endogenous eczema, it is triggered by the exogenous factors, and that we consider it into the atopic dermatitis. In atopic dermatitis, we studied about the atopy. So what is atopy? See, atopy is what? That is a like localized form of, we studied that atopy is the type 1 hypersensitivity, and in details if you want to know what is that actually in actual terms, so it is the localized form of type 1 hypersensitivity reactions. It is the localized form of type 1 hypersensitivity reactions, localized terms of type 1 hypersensitivity reactions. Okay, in case of atopy, we are getting the tride, so they are the atopic tride. They are the atopic tride. What are the atopic tride? In case of atopic tride, remember, we will remember there will be the recurrent allergic rhinitis. What we will see? Recurrent allergic rhinitis, and it involves the upper respiratory tract. See, rhinitis means inflammations of the nose part, so that can be the like we can see coryza. Okay, all these things, upper respiratory infections will be seen in upper respiratory infections. Then we having the atopic asthma, or we can say the bronchial asthma. The bronchial asthma or atopic asthma, that is again due to atopy conditions, and atopy, what we see, it is due to lower respiratory tract. It involves the lower respiratory tract, like the bronchus and also bronchial asthma. The obstructions, everything we discussed already about the bronchial asthma. Third atopy includes that other, but this is the localized form of type 1 hypersensitivity, so it includes the allergic rhinitis. So we also know the rhinitis, it is also an example of the type 1 hypersensitivity. Bronchial asthma, we studied, that is also an example of type 1 hypersensitivity. Then we having the atopic dermatitis. Okay. Then in case of atopic dermatitis, we already discussed about the bronchial asthma and all, but here we are discussing specially about the atopic dermatitis. In atopic dermatitis, it can affect the infantile, it can affect the childhood, it can see in the adults as well. So in case of like atopic dermatitis, if it is what? Infantile conditions. Infantile, here I am taking 0 to 2 years children. Normally infant is 1 till 1 year of the age, but here I am taking the age up to the 2 years. So in these conditions we see the lesions, and these lesions are the papulovesicular lesions. They are the papulovesicular lesions will be there, and along with that it will be exudative. It will be the exudative. Mainly these papulovesicular lesions, they will present on the face, they will present on the scalp region and extension of the extremities, Okay. So which type of the rashes that you should remember? What are these? These are papillovesicular rages, and they are the exudative. Just remember the name, and like for the, you don't need to remember what is the papules, macules. For now just remember there are some papules, vesicles, macules, all these type of the findings we'll see, but here you can remember they are the papillovesicular lesions. After that, infantile, we will be having something, the infections, that is in atopic dermatitis in childhood. So in the childhood, like 2 years till the puberty, till puberty. So in till puberty, we see in this condition there will be the red, there will be the scaly and papules. Along with that, along with the papules, we see the plaques. Along with that, we see the lichenifications. Lichenifications will be also seen in case of the childhood intervals. And also see these rashes or the site, if you say, they are present on the extensor, but in case of the childhood they are more common in the flexure part, in the flexure compartment. They can also seen in the adult as well. In case of the adult, remember, in case of adult you need to remember that in case of like after the puberty, there what we will see, there is a lichenifications, there will be the lichenifications will be seen. One major hallmark you need to remember for the atopic dermatitis, if you are seeing pruritus, one major other hallmark, that is pruritus, the hallmark of the pruritus, that is the hallmark of atopic dermatitis. It will be the intermittent, and intense. It will be the intermittent and intense, and that's termed as like the itchings, that itching like the rash that itchings, itching. So they are like pruritus, the intermittent and the intense rashes, that itchings. So these are the hallmark features of what atopic dermatitis, that you need to remember very very clearly. Okay. Then we ask about the treatment in the question. So for remember the treatment, see, if we having the some any inflammation is there, so we can give the topical steroids. We can give the topical steroids. So they are the anti-inflammatory. Along with that, you need to remember, if we will be having any like the thick papules or thick vesicles, so in that conditions we can give for ointments, we can give some ointment. Other than that, like if the patient having the scaly and there is scaly or subacute eczema is present, so in that things we will use any neutral creams. We used any neutral creams that we discussed yesterday. So if you have the scaly and oozy subacute eczema, so in that conditions what we will use? We will use the any neutral creams we can prefer. Okay, so this is what about the acute dermatitis. So now you can see the question. We will be having atopic dermatitis. So what recommendations? So what we will give? Use of the, this is the direct question, so we can easily use of the neutral creams to protect the screens. So this is mainly like if we having the atopic dermatitis, so mainly for the to prevent any exacerbations we use the neutral creams. But we can use the steroids in case of if having the any inflammations is there. So in that conditions we can use the steroids. But also we don't use the systemic. We use the topical steroids. If you want, we use the topical steroids to prevent any inflammations. Okay, that's why this is not a answer. Is my audio breaking? Is it for everyone? Hello. Hello. Is my audio breaking? Audio brain, now it's okay. Please shows complete slide once again. Okay. Okay, can you please just message me if like any if you want to do any message, better message in the group. Okay. If I like have any problem, just message me in the group or message me personally, because I'm not connected with internet, so that's why. I think it will be okay for now. Okay, I'm showing the complete slide again. See, or I'm repeating it again. Atopic dermatitis, there is a chronic relapsing inflammatory skin disease, and we are having the endogenous eczema. We will be having reactions pattern to this. Eczema is what? Reaction pattern of the skin that is secondary to the endogenous or exogenous tumuli. Atopy we studied, that is the localized form of the type 1 hypersensitivity, and this is atopic triad. The recurrent allergic rhinitis, atopic asthma, bronchial asthma. Okay, bhai. That is atopic asthma, bronchial asthma. ये तो already I studied, tell you ना, that's why I'm little fast. See, atopic asthma, bronchial asthma, atopic dermatitis. The atopic dermatitis क्या होता है? That is the infantile, childhood or the adults. In infantile, where the lesions like papillovascular lesions or the exudative, the side, the face, scalp and the extension of the extremities, it will be present. If you are telling about the childhood conditions, there is the red scaly papules plaque or the lichenifications, and where it will be, it will present on the flexor side. In the adults, we will see there is a lichenifications will be there. Lichens formations will be seen. What is the hallmark you need to remember for the atopic dermatitis? So you can remember there is a pruritus. In the pruritus, we say the intermittent and intense rash, that itchings. Treatment we see there is a topical steroids, anti-inflammatory ointment, or we can give the neutral cream, that is the scaly or oozy subacute eczema. Along with that, if we see there is any thick inflammation or thick papules or the vesicles is there, in that conditions we can use the ointment. Okay, that you need to remember very clearly. If you will just revise these questions, then it will be easily understood. Okay. Then these questions we already done. Encephalitis, this question we already discussed yesterday, so I'm just little bit fast for now. So prednisolone, this question we also does. High hyperglycemia, everything does now. And after that, let's come back to the question number 67. A 10-year-old child has been followed up for the dilated cardiomyopathy. So let's discuss before the cardiomyopathy only. See, cardiomyopathy. What is the cardiomyopathy? So write down the headings. Cardiomyopathy. See, cardiomyopathy, when we discuss, these are some myocardial disorders, like we are having the endocarditis that we studied, like Liebman-Sack endocarditis, subacute, acute endocarditis, or maybe you studied in the like IV use patients. So in that condition we discuss endocarditis. But here we are talking about the cardiomyopathy, that is myocardial disease, means myocarditis will be there. So this is the let's note moya. It's myocardial. It is the myocardial disorder in which the heart or structurally and functionally abnormal in absence of any chronic artery disease, hypertensions, or the valvular heart disease or congestive heart disorders. So these are the myocardial disorders in which heart is structurally, means structures will be abnormal, and problem with functions as well, and functionally as well, and functionally abnormal in absence of CAD, that is chronic artery disease, hypertensions, HTN, hypertensions, valvular heart disease, and congestive heart disease. So this is the problem with having the myocardiums. So it can include the dilated cardiomyopathy, DCM, that full form we will write here. Dilated cardiomyopathy, it can include the HOCM, hypertrophic cardiomyopathy, or we can remember just hypertrophic obstructive cardiomyopathy, or you can write it as just HCM. So that is also correct. Then we can having the restrictive cardiomyopathy. This is the restrictive cardiomyopathy. So these are the different types of cardiomyopathy. So these are the important cardiomyopathy that we will discuss. The next one is what we will be having, that is the DCM, that is dilated cardiomyopathy. dilated cardiomyopathy. See, in case of the dilated cardiomyopathy, when we discussed about the dilated cardiomyopathy, so as the name is telling us that there is a dilatation. So dilatation of which structure? The dilatations of the all the four chambers are dilated in these conditions. This are all four chambers. The heart have the four chambers: left atrium, right atrium, left ventricle, right ventricles. So all four chambers will be dilated. All four chambers will be dilated. Then remember, which is the most commonly chamber affected, that is the left ventricles. In the left ventricles, what we see, there is a thin dilated left ventricles. There are thin dilated left ventricles with systolic dysfunction. What is the systolic? The systolic, the contraction phase. So in the contraction phase, there will be the systolic dysfunctions will be there. What is the most common cause of the dilated cardiomyopathy? Always remember, that is the idiopathic. That is the idiopathic, that is unknown. Along with that, alcohol can also cause the dilated cardiomyopathy, and along with that, there is a problem affected with the titin genes, or the titin gene mutations can also lead to the dilated cardiomyopathy. In case of the dilated cardiomyopathy, remember, this is the most common cause of heart failure. This is the most common cause of heart failure with reduced ejection fraction. With the reduced ejection fractions. This is what? Ejection fractions. Ejection fractions. See, what is the ejection fractions? The how much blood is ejecting. So in the fraction, so that is what ejection fractions. So there is a most common cause of heart failure with having the reduced ejection fraction, that will be called as the dilated cardiomyopathy. Then next is what? That is the HOCM. That is the HOCM, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, it is the genetical condition and it is the autosomal dominant. It is the autosomal dominant conditions. So in autosomal dominant conditions, remember, hypertrophic. So which structures will be hypertrophied? Yani ki there is increase in the size. Hypertrophy means increase in the size. So in case of hypertrophy of which structure? The hypertrophy of interventricular septums. So we are having the heart, and in the heart, if we having this structure is affected, so that will become the, this structures will become the hypertrophied. The hypertrophied of the interventricular septums. So that will be the increase in the size. And due to which we will see there is a banana shaped heart formation. The heart will become the banana shaped heart. The heart will become the banana shaped heart. And other most important point you need to remember, the most common cause. It is the most common cause of death. The most common cause, or you can write the most common cause of the sudden death. That is the accurate one. The most common cause of the sudden death in young athlete peoples. In young athlete peoples. So it is the autosomal dominant condition. There is hypertrophy of interventricular septum, banana shaped heart, most common cause of the sudden death in young athlete peoples. So that is what? Hypertrophic cardiomyopathy. That is hypertrophic cardiac myopathy. Okay, which mutations here? Beta MSC mutations. Beta MSC mutations will be there. Okay. After that, there is one more things. They like we having the RCMs. RCM, that is the restrictive cardiomyopathy. Restrictive cardiomyopathy. So the restrictive cardiomyopathy means then there will be the some restrictions. So there is which restrictions means there only having the right ventricles will be affected. The only right ventricles will be affected. The only right ventricles will be affected. Wow, nice. There will be the right ventricle affected. In right ventricles, what we will see? In the right ventricles, we will see the loads of fat. Loads of fat will be there. Okay, that you need to remember about the restrictive cardiomyopathy. What is the most common cause of restrictive cardiomyopathy? The most common cause, that is amyloidosis. Amyloidosis. And also remember, in case of like the RCM, we will see there is a diastolic dysfunction. This is again the most common cause of the amyloidosis, and after that we can having the diastolic dysfunctions that can be the cause of the restrictive cardiomyopathy. Okay. There is a one conditions we call as the hemochromatosis. There is one conditions we call as the hemochromatosis. So in case of hemochromatosis, remember, we know that in hemochromatosis we will be having iron overload. What will be having? Iron overload. So iron overload, this is most common in the DCM. What is that? Dilated cardiomyopathy more than RCM, restrictive cardiomyopathy. That you can also remember, that can help you, like it helps, like there's some tricks can given in the questions, or the some keyword you can find in the questions. Okay, so that you need to remember. Okay, after that there is hemochromatosis, iron overload, DCM, that is the more common, and then the RCMs. So that you need to remember. Now in the questions we are getting the some. Now let's come back to the questions. We have the dilated cardiomyopathy. The child is present with the dyspnea and the cardiology. There is the dense non-mobile edemata. So there is edema problems. Okay, on the lower extremities, yes, that can be seen in case of the edema. We can see in case of the, like if they have the reduced ejection fraction. So in that conditions we can see, or any problem with the congestions, any problem with the heart failure. So in that things we can see the edema. In the heart failure conditions we can see the edema. The cardiac borders are extremely extended transversely. Heart sounds are muffled, blowing systolic murmur at the apex and over the xiphoid. The liver is 3 cm enlarged. Urine output is reduced. The blood total protein 58.6 gram per liter. The urine protein is WBC is this, RBC is this. What is the main mechanism of edema syndrome? So he is asking about the main mechanism of the edema syndrome development. See, asking like why and how the edema is developed. So this is mainly due to congestions, or mainly due to like hyperemia condition. They are like something like very common things. So let's discuss about what is, sometimes we write hyperemia, sometimes we write the congestions. So actually what it is. See, whenever you talk about the hyperemia and congestions, see, in both these conditions, the hyperemia, or whether it is hyperemia, whether it is congestions, if there is an increased blood flow in the dilated vessels, there will be the increased blood flow in dilated vessels. There is an increased blood flow in dilated vessels. There is a increased blood flow in the dilated vessels. So the vessels, they will like, if any vessels means both arteries or the veins. So vessels, if artery is dilating, so in both these conditions there is an increase in what blood flow will be there. The increase of what blood flow will be there. So that condition we can say hyperemia, or we can say the congestion. See, there is one condition we having the hyperemia. See, in hyperemia, what will be there? It is the active process. Hyperemia is what? It is the active process. And in case of like hyperemia, we studied like there is a arterial hyperemia, venous hyperemia. So mainly there is, in when we talk about the hyperemia, so we talk about the arterial mainly. So mainly we having the, it is due to, we can say, arteriolar dilatations. So mainly this is due to arterial dilatation. due to arterial dilatations. So if artery is dilating, so which color will be seen or how the skins will be looking? So the in that conditions we will be having the red in color, the red in color. Why? Because the arterial, because there is increase the oxygenated bloods. Like for example, if having the inflammations, so in case of inflammations we are having something arterial dilatations, and due to which our skins will be looking more reddish. So that condition is known as the hyperemia. That's why we consider, we write somewhere, hyperemia means redness. Hyperemia means redness. So that is means of what hyperemia or redness. Then other is what? Congestions. See, in congestion, when we are talking about the congestion, again there is increased blood flow in the dilated vessels, but the congestion is the like the passive process, not required like any energy and anything. So it is the passive process, and it is due to impaired venous outflow. It is due to impaired venous outflow. If venous outflow is impaired, so in that conditions we will be having the congestion. We will be having the congestions. So here we will be seeing blue red in color. There is a blue red in color. Why the bluish color is there? Because venous. Here we can say the venous blood, and this is the deoxygenated blood. This is the deoxygenated blood. And like for example, this is seen in case of the right heart failure. So as we see, in case of the heart failure, we will see the congestions will be there. There will be the congestions. For example, if we are having the right-sided heart failure, for example, if we are having the right-sided heart failure, right-sided heart failure, HF is what? This is the right, this is sided heart failure. So in right-sided heart failure, we will be having the systemic venous congestions. We will be having the systemic venous congestions. Okay, sometimes we also call the right-sided failure as the congestive heart failure. So what is the difference between the right-sided heart failure and the congestive heart failure? See, congestive heart failure. In congestive heart failure, there is involvement of the lungs. But in the right-sided heart failure, there will be the systemic venous congestions with lungs spared. Lungs will not be affected. The lungs will not be congested. But in congestive heart failure, we can see the congestions of all the organs, congestion of all organs including the lungs. Okay. Then there is a other condition, that is the left-sided heart failure. The left-sided heart failure, then you need to remember, in the left-sided heart failure, there will be the pulmonary venous congestions. There will be the pulmonary venous congestions. The pulmonary venous congestions will be there, and in pulmonary venous congestion we can see that there will be the pulmonary hypertensions. If we are having the pulmonary venous congestions, that can lead to the pulmonary hypertensions, and that can lead to the right-sided heart failure. That lead to the right-sided heart failure. See, when the pulmonary venous congestions will be there, firstly it will lead to the pulmonary edema. And that edema further will lead to the pulmonary hypertensions, and if pulmonary hypertensions will complicate, then it will lead to the right-sided heart failure. So it says that right-sided heart failure, what is the common cause that we seen in case of the right-sided heart failure? That is the left-sided heart failure is the cause of the right-sided heart failure. Okay, sometimes the main cause of the right-sided heart failure is only the left-sided heart failure. It is due to left side, जो left right वाला जो heart है वो left की वजह से basically fail करके जाता है. Okay, that you need to remember. So you can see here the congestions means like if any congestions. I hope you all are clear. See, we having the heart. In the heart we having the left atriums, we having the right atrium, or we having the right atriums, we having the left atriums. This is left ventricles, right ventricles. From the left ventricles we have the aorta will be rise, and from the right ventricles we will be having pulmonary artery will be rise, and from left ventricles aorta will be rising. Here what we having, pulmonary veins will be there, pulmonary veins. So these pulmonary veins, what they carry? They carry the oxygenated bloods. The pulmonary veins, they carry the oxygenated bloods. Okay, they are the major vessels. See, if pulmonary, if having the left-sided heart failure, so in that cases the blood will accumulate into the left atriums. The blood will accumulate into the left atriums. So if the blood will accumulate in the left atriums, can I tell you that if blood accumulate in the left atrium, the blood is not going into the left ventricle, because left ventricles, it is not able to pump the blood effectively. So that's why all the bloods will accumulate here. After that, this blood will accumulate here, and this blood will accumulate into the pulmonary veins. Is that we can call edema? Is not edema, is that any blood accumulations or any fluid accumulation is what we call edema. So can we call this as the pulmonary edema? So we can call this condition as the pulmonary edema. So yes, the edema is edema can be the cause of cause of edema can be the congestions, and that congestions can cause the left ventricular heart failure, or it can be the right ventricular heart failure also. I hope this is clear, and sometimes voice breaking via. कर लो यार, थोड़ा सा एडजस्ट कर लो, कोई नहीं, समटाइम्स हो रहा है ना, ठीक है, जो तो हो जाता है यार कभी कभी. आई थिंक वेदर टुडे इज नॉट गुड, सो दैट्स व्हाई मे बी. Let me connect with. हेलो 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 हेलो, कहाँ गए? Okay, I hope now I tried to reconnect, so that's why. Okay. Hello, hello. Just gives me thumbs ups. Oh, okay. So see where I was in the, when we are having any problems with the left ventricle. So the left ventricle, if any problems or having the like any the left ventricle ejection fraction is lost, the systolic dysfunction is there, so the left ventricle will not able to pump the blood. So when the left ventricle not able to pump the blood will accumulate here, and when the blood will accumulate here, that blood will accumulate into the left atrium as well, and there will be the backflow of the blood. एंड लाइक एट्रियम जो हार्ट है वो बोलेगा वेन्स को तो अपना ब्लड वापस ले ले, आगे काम नहीं चल रहा है ना. इन द फर्दर फ्यूचर प्रोसेस दिस इज नॉट वर्किंग, सो इट विल टेक द ब्लड्स in the reverse directions, and then this blood will accumulate. Any blood accumulation, any fluid accumulation, what we call the edema. So now you can understand from here, from this point, because this is the simplest things I can tell you, and from the simplest things you can understand the difference. You can simply understand the concept between the congestions, edema and hyperemia. All these things you can understand. All these are like any heart failure, they can cause the edema. Like for example, if having the right ventricle failures or the right sided heart failure will be there, there can be the edema of the lower limbs as well. Why the lower edema? Because from the right atrium, so right atrium, which veins is there, that is the superior vena cava and inferior vena cava. And this inferior vena cava, it is where, from where it is coming. It is coming on the long way from our legs, then against the gravity. And when, if the right atrium is, or right sided heart is not working, so the blood will accumulate into the lower limbs, and that will cause the lower limb edema. So any conditions, like we can having the pulmonary vein congestions, or we can have the intraventricle, we have the pulmonary artery, IVC, SVC, pulmonary vein or aorta, they are the greater circulations. They play major role in the greater circulations. I hope this is every one of you know already. If no, just go through my Croak 1 notes, then you will able to understand that basic things that you, if you don't know these things. See, there is a left atriums, left ventricles, aorta, or all these like whole circulations you should remember by just by your mind. So that should be clearly in your minds. That's why you will can easily make, okay, this condition is what we will be having the right sided heart failure, congestive heart failure, we having the left sided heart failure. Okay, if you having the left sided heart failure, our left ventricles will not able to pump the blood, and if the left ventricle will not able to pump the blood, this blood will accumulate into the left atriums, and when this blood will accumulate into the left atriums, so there will be the accumulation of what, the blood in the pulmonary veins, and that will lead to the edema, or we can call this as the pulmonary edema. So this is the like simplest things that I can tell you according to the what are the congestions and edema things. So now you can easily understand that if according to our questions we have the edema of the lower extremity, it can be the lower extremity of the sacrums, like on the right sided conditions. If we having the problems like the lungs, there is edema of the lungs or edema of the pulmonary veins, that can be the problem we having the based on the pulmonary veins. So we can easily say, okay, this is what venous congestions, because if there is a edema on the lower limbs, if there is a edema on the lower limbs, then we can see that there is a problem with the inferior vena cava. The inferior vena cava is not able to pump effectively. So that's why we can say there is a venous congestions of the which circulation, that is the greater circulations. Okay, that you need to understand. So edema, you can remember from today that edema, okay, this is due, can be due to congestions, that can be due to congestions, or it can be due to hyperemia as well. There is a redness things. Okay, so that is the thing. So venous congestion of the greater circulations. I hope this is clear. Okay, maybe you've heard about what is the nutmeg liver, है ना, वो बहुत सारी चीजें थी. The nutmeg liver was there, and along with that you can see there can be the heart failure cells as well. So see, if we having the example of congestions, if I discuss in detail, so there is some other example of pulmonary example of congestions. See, if there is can be the acute pulmonary congestions, there can be the acute pulmonary congestions, there can be the acute pulmonary congestions. So this acute pulmonary congestions, it is characterized by the focal hemorrhage. It is characterized by the focal hemorrhage, alveolar edema. Now you can see, if you have the acute, what is the meaning of pulmonary congestions? Pulmonary congestions means dilatation of the pulmonary vessels. There is a focal hemorrhage, there can be the alveolar and the septal edema can be there. What happen in the chronic pulmonary congestions? There will be the heart failure cells will be there. There is one more condition that we call acute hepatic congestions. See, when we talk about the acute hepatic congestions, so always remember, in case of acute hepatic congestions, we see there is a centrilobular necrosis. क्या देखने को मिलेगा? Centrilobular necrosis. Along with that, what we can see, there will be the fatty changes will be there. So centrilobular necrosis and fatty changes will be there. Then other things we will be having, that is the chronic hepatic congestion. Chronic hepatic congestions. So in case of chronic hepatic congestions, remember what we see, we called it as the nutmeg liver. We called it as the nutmeg livers. What will be there in chronic venous congestions? What will be there in chronic venous congestions? In spleen. So this is why when you're talking about the hepatic, in chronic hepatic congestion, we call this as the nutmeg livers. Now you usually understand. Now if anyone will ask you what is the nutmeg livers, those who you are seeing in every question there was some keyword, everything was there like nutmeg liver, nutmeg liver, nutmeg liver. So what was that? It was the chronic conditions having the hepatic congestions, or there is a, you can say, abnormal vessels in the liver that becomes dilated. The chronic venous congestion in spleen, we call this condition as the, yes, gamma Gandhi body. Gamma Gandhi body. Okay, you can call this whatever you want. Gamma Gandhi body. So in gamma Gandhi body क्या होगा? Fibrosis होगा, calcification होगा. There is a fibrosis, calcifications, hemorrhage, everything will be there. So just remember the names, as this question was like in many croak questions, like croak 1 also. So that's why I gave you the idea. So that is what is the chronic hepatic congestions. Okay. So this was all about the congestions. I'm just repeating it once again. So we are having the hyperemia, the congestions due to arterial dilatations, congestions due to impaired venous outflow. This is the red in color, and the blue. This is blue red in the color. There is inflammations, right hepatic failure, right-sided heart failure, congestive heart failure, and the left-sided heart failure will be there. So that the pulmonary venous congestion that cause the congestion of all organs, the right-sided heart failure, the congestive heart failure. I tell you the difference. What is the difference? Sometimes we call it congestive heart failure, sometimes we call it right-sided heart failure. They are quite similar, but the involvement of the lungs is there. That means congestive. If involvement of the lungs is not there, so that is the right-sided heart failure. Then we are having the acute pulmonary congestions. We studied that is the focal hemorrhage, alveolar or septal edema will be seen. Acute hepatic congestion, there is centrilobular necrosis or the fatty changes. Chronic hepatic congestion, we studied that there is a nutmeg liver. So venous spleen, we say there is gamma Gandhi bodies. Okay, I hope this is clear and this is done. Okay. Then we will be having the next questions that we already discussed. Then let's discuss about all the hemorrhages. See, when we discussed about the hemorrhage, so we were having like we can say the intracranial hemorrhage. The intracranial hemorrhage. Intracranial hemorrhage. This is again the very important topic, so that you need to remember. The intracranial hemorrhage, we studied that the first of all I already discussed with you. We having, so this is what we have the scalp, and below this is what we have the scalp regions. Below the scalp we having some meninges, and we call it the brain meninges. So the outer layer is what? That is the dura mater. The outer layer is the dura. I'm making the rough diagram. In the dura mater also we having the two layers. In the dura mater we have the two layers. One layer that is directly attached to the scalp, and other layer that is make the great covering or the outer covering of the brain. Then we having the dura mater. Below the dura mater we will be having below the dura mater we will be having the subarachnoid mater. Below the dura mater we have the arachnoid mater. We will be having the arachnoid mater. Then below the arachnoid matter we will be having the pia matter. We will be having the pia matter. So we can see that outer layer, this one is the scalp, then this blue color is what? This blue color is the dura mater. The blue color is the dura mater. Above the dura mater and below the dura mater. Below the dura mater we will having a space, and this space is known as the subdural space. This space is known as the subdural space. And above the dura mater we having the space that is known as the epidural. So above we having the epidural space. Above we having the epidural space. Below we will be having the subdural space. We having the subdural space. This green layer is what? This is the arachnoid matter. This green layer is what? That is the arachnoid matter. So below the arachnoid matter we will be having a space that is filled with the CSF. This is filled with the CSF. That is very important. So we having the CSF here, and this space is known as the green one is what? That is subarachnoid. Can I write it just as A? So this is what? Not subarachnoid. This is what? Arachnoid. The layer is what? That is arachnoid. Arachnoid. The space here is what? That is the subarachnoid space. Sub means below. So that is below the arachnoid. This is the subarachnoid space. Then below layer, that will here is what? This one. This one is what? That is the pia mater. This one is the pia mater. So epidural space, dura mater. Subdural space, arachnoid mater. Subarachnoid mater, pia mater. Then below the pia mater we were having the brain, and this brain, the whole part of the brain, we call this as the intracranial, or we can say parenchymal. Okay, so let's discuss one by one about, like we're having the subdural, epidural. So let's first discuss if we have any bleeding here in this space. So the first hemorrhage we having, that is the epidural hemorrhage. So we have first hemorrhage we having, that is the epidural hemorrhage. In epidural hemorrhage, what is the source of epidural hemorrhage? Say hemorrhage means bleeding. Epidural means above the dura mater there is a space where we can see the bleeding. In epidural space there will be the arterial bloods. Which blood will be there? Arterial blood will be there. So we need to know which artery will be affected. So you need to remember we have the most common artery. The most common artery affected, that is the MMA, mama. That is mama. That is mama. That is mama. Okay, that is middle meningeal artery will be affected. Middle meningeal artery will be affected. Okay, this is the most common artery affected is the middle meningeal. See, we having the temporal side. On the temporal side, below the temporal part, we will be having this artery is affected. So if any hit on the temporal side, we can having the epidural hemorrhage. What is the cause of that? The cause, most common cause is what? Trauma. The trauma is the most common cause of epidural hemorrhage. See, in case of epidural hemorrhage, okay, just come back here. See, in case of acute, so in case of like the person, if any person is there, if any like the cricket player, I hope everyone of you know what is the cricket. So in the cricket we are having any ball. If any ball is playing and any ball is hitting on his temporal side, and that person fell down. That person fell down, and when the person fell down, he again stand up again quickly. He stand up again quickly. He playing very fastly. Okay, he got the okay. उसको काफी like गुस्सा आ गया. He got very angry issues, and okay now he's playing that he's making a 6, 4, everything. He's making good score. And after once he completed the whole batting and everything. So after 2 hours, 3 hours, he got sudden collapse and he got dead. So what this interval is? So this interval we called is the lucid intervals. ओके, आई एम रिपीटिंग इट इन हिंदी, ठीक है। एक क्रिकेट प्लेयर है, ठीक है, वो अपनी बैटिंग कर रहा है, ठीक है, वो बैटिंग करते करते ही गोट द हिट, और उसको एकदम टेम्पोरल साइड पे आके उसको एकदम से यहाँ पे बॉल हिट की, और एकदम से जैसे उसके बॉल यहाँ पे लगी वो एकदम से नीचे गिर गया, और जैसे ही वो नीचे गिरा एकदम से सडनली वो उठ गया, ठीक है, नीचे गिरा, थोड़ी देर ऐसा हुआ कि कुछ हुआ उसको, आफ्टर दैट वो सडनली उठ गया। उठने के बाद उसको गुस्सा आया कि बहुत ज्यादा मतलब क्या हुआ, इतनी मतलब फास्ट बॉल उसको लगी, तो उसको एकदम गुस्सा आया, उसने अपना अच्छी सी पारी खेली, 50 बनाया, शतक बना लिया, सब कुछ बढ़िया कर लिया। एंड आफ्टर दैट वो अपने जब जैसे ही बैटिंग खत्म हुई, ठीक है, ही गॉट आउट एंड वट एवर, आफ्टर 2 to 3 hours ही गोट सडनली एकदम से उसकी डेथ हो गई, सडनली वो कोलैप्स कर गया। सो दिस इंटरवल, इस इंटरवल को हम क्या बोलते हैं, ये इंटरवल क्या होता है हमारे लिए, दैट इज लूसिड इंटरवल्स। So this lucid intervals we see in case of the which condition, epidural hemorrhage. This is called the lucid intervals. So this is what the clinical features where we see the lucid interval. This is the lucid intervals. So this is the what the lucid intervals that we see in case of the epidural hemorrhage. Like the person will become unconscious, then again become the conscious, and after that the persons become again unconscious and sudden death. Unconscious, okay? Unconscious, and after that person's just sudden death will be there. So this is what the lucid intervals in case of the epidural hemorrhage. When we do the CT scans, we see there is some finding is there, and we see there is something we can go, that is the lentiform opacity. We see there is a lentiform opacity, or we can say there is a lens shaped opacity. The lentiform opacity or the lens shaped opacity. The lentiform opacity or the lens shaped opacity we see in case of the CT scans. You forgot to say, okay, sorry, thank you, sorry. Okay, now screen is visible. Okay, thank you. See, we having the, so where we have the clinical features. So we will be having the lucid intervals. So the lucid intervals, we can see there is a unconscious. After that, people will become the conscious, and when again this person will become conscious, and there is a sudden death will be there. So this interval is called the lucid intervals. When we do the CT scan, see, when we do the CT scans, we see having the lentiform opacity, or we will be having the lens shaped opacity will be seen. So we have the lentiform opacity or the lens shaped opacity will be seen in case of the CT scans, and this type of the findings will be there. So this is what convex type. This is what convex type, or you can remember it like idli. Okay, the idli shaped. This is just for Indian student. This is what idli. The idli is like some क्या बोलते हैं उसको, ठीक है, कुछ है, just for Indian student, just remember that like the idli shaped, and it's the Indian dish. Okay, that is the convex type. So this type of the, like if you are having the brain, and in the brain we see there is a something, this type of the whiteness area will be seen on the CT scan, and that we called is the lentiform opacity or the lens shaped opacity or the convex type or the idli shaped opacity will be seen. The next is what we having, that is the, so next one is what we having, the subdural hemorrhage. Subdural hemorrhage. So in subdural hemorrhage we can see they are having the subdural space. If any bleeding at a subdural space, at this space, we called it as the subdural hemorrhage. See, we have the two findings. One is what we having the subdural, one is what we having the epidural hemorrhage. One we called it hemorrhage. There are the two conditions now. When we call it hemorrhage, and one we having the hematoma. So what is the difference? Hemorrhage is the bleeding. Okay, medical term for the bleeding is what? Hemorrhage. But if we called it like the hematoma, so hematoma is what? If any fluid is accumulated in a particular area, we called this as the hematoma. Okay, so here is what we having the subdural hemorrhage. Here is what we having the subdural hemorrhage. What is the source of the subdural hemorrhage? The source of subdural hemorrhage is the venous blood. The source of subdural hemorrhage will be the venous blood. So in case of the venous blood is there, see in epidural we studied that there is a involvement of the artery. There is the MAMA, middle meningeal artery. So there will be the arterial blood, oxygenated blood will be there. But here we are seeing there is a venous blood. So which veins will be affected here? Which veins will be affected? So that is what? Bridging veins. There is the veins that connect, that is the bridging veins will be affected. The bridging veins will be affected in case of the subdural hemorrhage. What is the cause of that? Again, it can be due to trauma. It can be due to trauma. It can be due to anticoagulant drugs. It can be due to anticoagulant drugs. It can be due to antiplatelets drugs. It can be due to any alcohol abuse. And there is one syndrome that is associated with the subdural hemorrhage. That is, just remember the name for that. That is second baby syndromes. That is the second baby syndromes. Okay, that is the subdural hemorrhage. See, subdural hemorrhage na, it can be the acute or it can be the chronic. It can be the clinical features what we see, it can be the acute conditions and it can be the chronic. Is lucid interval can also be seen in the subdural hemorrhage? Yes, but remember the most, I will not write it here, otherwise you will confuse. The lucid interval, the maximum lucid intervals that we seen in case of the epidural, or more commonly that is seen in case of the epidural hemorrhage. Here we can also see the lucid interval, but not that much or not that common. But here in the acute phases we see the lucid intervals. In the chronic phases, along with the there is no lucid intervals, we see the person will be having the drowsiness will be there, the patient will be having the headache will be there. Okay, that you need to remember. Then next one is with what we having, that is the subarachnoid hemorrhage. Subarachnoid hemorrhage. See, in case of the subarachnoid hemorrhage, when we talk about the subarachnoid hemorrhage, always remember it is in, this is the important. Why this is important? Because in subarachnoid we having what? CSF. We having which? We having the CSF fluid. So the CSF fluid that is present in the subarachnoid space. So this subarachnoid hemorrhage, what we having, the source is what? That is the arterial bleed. The source is what? That is the arterial blood will be there. So again this is the arterial problem, and remember that the most common cause for this condition is what? That is the trauma. The most common cause for this condition is the trauma. And other than why the arterial blood we are saying, see the second most common cause, that is rupture of Barry aneurysms. So the Barry aneurysms, that involvement of the arteries, that's why there will be the rupture of Barry aneurysm. But again remember that is the second most common cause. If you are getting the trauma in the questions, so mark that. But sometime you can remember for the subarachnoid hemorrhage, the Barry aneurysm is also very common. But the most common cause is what? Again, the trauma is there, but the second most common is what? The rupture of Barry aneurysms. So if you are getting any question in which trauma and rupture of Barry aneurysm is there, so the trauma is the most common cause that you need to remember. Okay. Then after that, if the person of any patient of the subarachnoid hemorrhage came to you, the person will say that, doctor, I have the severe headache and this type of headache never came in my life. This type of headache never came in my life. This is called the worst headache of the year. Worst headache of the life, not year, worst headache of the life, and it is, we called it as the known as the thunderclap headache. This is the thunderclap headache and the worst headache that seen the people feel in their life. Thunderclap headache, there can be the neck stiffness can be present, along with that there can be the absence. Neck stiffness can be present or it can be the absence. So in case of the subarachnoid hemorrhage, we having the arterial blood. The most common cause is what? That is the trauma. The second most common cause is the rupture of berry aneurysm. There is a thunderclap headache with the neck stiffness present or neck stiffness can be absent. So this is the case of the subarachnoid hemorrhage. And this is very important that you need to remember. So if you having the arterial blood is there, you can see the most common cause is the trauma. Along with that, you need to remember there is a berry aneurysms, and you need to remember there will be the thunderclap headache with the neck stiffness present or may be absent. Okay. Then the fourth one we having, that is the intraparenchymal hemorrhage. The intraparenchymal hemorrhage. Okay, the intraparenchymal hemorrhage. See, in intraparenchymal hemorrhage, this is the most common type of intracranial hemorrhage. This is the most common type of intracranial hemorrhage. Okay, what is the source? The most common type of the intracranial hemorrhage is what? Intraparenchymal hemorrhage. The source here again is the arterial bleedings. There is again here what we see, arterial bleeding. So venous bleeding, you can remember, it is seen only in the subdural hemorrhage. In all those conditions we see, all other conditions we see arterial bleeding. What is the most common cause of intraparenchymal hemorrhage? That is the hypertension. That is the hypertension. What is the most common site? The most common site, again that you need to remember, the most common site for the intraparenchymal hemorrhage, that is the putamen. And the putamen we having the basal ganglia. The putamen will be having the basal ganglia will be there. Then after the putamen we will be having the thalamus. Then we are having the cerebellum or pons. But most common site that you need to remember is what? That is the putamen. Putamen, it is the part of the basal ganglia. The putamen, it is the structures present in the basal ganglia. That is the most common site of intraparenchymal hemorrhage. So this is the very important hemorrhage that we need to discuss. See, epidural hemorrhage, there is artery. The most common artery affected is the middle meningeal artery. The most common artery affected here is the middle meningeal artery. What is the cause of that? The cause is the trauma. Lucid interval will be present in the EDH. Lentiform opacity or the lens-shaped opacity, that is also present in the EDH. Then we will be having the subdural hemorrhage. In the subdural hemorrhage, which veins will be affected? Bridging vein will be affected. The cause here is the trauma, anticoagulant, antiplatelet, alcohol abuse, second baby syndromes. Then there is a drowsiness, headache type of the symptoms. Subarachnoid hemorrhage, that you need to remember, very important. There is a thunderclap headache, or you getting the worst headache of the life, or anything like similar keywords you can get. Most probably the answer would be subarachnoid hemorrhage. And the most common cause here is the trauma, and there can be the neck stiffness can be present, and the most common type of intracranial, this is the intracranial hemorrhage. The most common type of intracranial hemorrhage, that is the intraparenchymal hemorrhage. That is the intraparenchymal hemorrhage. And what is the most common cause of that? That is the hypertension. Then we having the hypertension. The most common site is the putamen, basal ganglia, thalamus, cerebellum, and the pons. Okay, that you need to remember very clearly. Okay, I hope this is clear. So in this question you can see, and along with that you can remember because that is the important in the case of the subarachnoid hemorrhage, you will be getting Hemorrhage and Babinski reflex. Hemorrhage and Babinski reflex. You will see in this type of the reflex in Croc 2 questions, but not other things, or not in other exams most probably. Okay, the antenatal internatal hypoxia, it was born in the asphyxia, child is progressing, there is also vomiting, nystagmus, spasm, and the spontaneous Hemorrhage and Babinski. What localization of the intracranial? So we have discussed already these things. Accumulation of blood between the arachnoid matter and the pia mater, there is Hemorrhage and the Babinski reflex. So that is what subarachnoid hemorrhage. That is what subarachnoid hemorrhage. Okay. This we already discussed. This again, watch glass by bronchiectasis. Okay, the next question is 73. A 2-month-old child after preventive vaccination had prolonged hemorrhage from the vaccination place and due to those intramuscular hematoma. During examination of child, I considered rise of prothrombin consumptions. So there is a rise of what? Prothrombin consumptions and a significant prolongation of the activated partial thromboplastin time. What is the most probable diagnosis? See, let's discuss a little about hemophilia. See, hemophilia, when we discuss the hemophilia, we are having the mainly we discuss about hemophilia A, hemophilia B, hemophilia C. So there are the three types. So hemophilia A, hemophilia B, hemophilia C. See, in case of hemophilia A, there will be the factor. I'm writing it like this. Actually, we wrote it like this, but this is very good to remember. That factor 8 deficiency. If factor 8 deficiency, or you can remember it like 8, 9, 11. So factor 9 deficiency and factor 11 deficiency. Okay, so hemophilia A, that is the factor 8 deficiency. Hemophilia B, that is the factor 9 deficiency. Hemophilia C is factor 11 deficiency. So these are three type of the hemophilia that we having. So this is the factor 8, no 8, no 11. So you can remember 8, 9, 11, 8, 9, 11, 8, 9, 11. Okay. So also you can remember 9, we can make the B. So this is opposite of the B, hemophilia B. Okay, A you can write. Okay, leave it, because you are more intelligent persons, so you can make the B also the 8. So don't forget this tick. Okay, just remember or just revise it 5 times. 8, 9, 11, 8, 9, 11, 8, 9, 11, 8, 9, 11, 8, 9, 11, ABC, ABC, ABC. Okay, 8, 9, 11. हिंदी में याद करना है इसको. 8, 9, 11 जल्दी याद होगा. So when we talk about the hemophilia, see the hemophilia A or hemophilia B, they both are the X-linked recessive conditions. Hemophilia A and hemophilia B, they both are the X-linked recessive conditions. They are the X-linked recessive. And I hope from Croc 2 point of view know that in X-linked recessive, if X-linked recessive is there, boys will be affected or the girls will be affected. We discussed in mnemonics that RBI, so boys will be affected. The boys will be affected. So that is RBI. RBI. What is the X-linked dominant conditions? X-linked dominant. So in X-linked dominant, the girls will be affected more. Girls will be affected. or that you can remember by the DGI. DGI. D dominant, girls will be affected. Recessive, boys will be affected. What is the factor 11 deficiency? So in case of the factor 11 deficiency, always remember, in case of the factor 11 deficiency, we will be having, this is the autosomal recessive conditions. This is the autosomal recessive condition. This is the autosomal recessive conditions that we see in case of the hemophilia C. So hemophilia C is autosomal because somal hemophilia C, or C is sound like S, so autosomal conditions, so autosomal recessive, so factor 11 deficiency. When we talk about the coagulations profile, the coagulation profile in means like we having the prothrombin time, the coagulation profile. The coagulation profile, remember, we having the normal, the coagulation profile will be the normal. The normal, like for example, what is the normal? The prothrombin time. PT is what? Prothrombin time. We having the platelet adhesion will be normal. Platelet adhesions will be normal. Fibrinogen, that is the protein, that will also, the clotting protein in the blood, that will also be normals. PT is what? Prothrombin time. PT is what? Prothrombin time. Except we see that there is an increase in what? APTT. What is the APTT? Activated prothrombin thromboplastin times, that you can write from here. There is an activated partial thromboplastin time. This is the APTT, activated partial thromboplastin times, APTT. So this will be increased in case of hemophilia. This will be increased in case of hemophilia. There is a one more questions where they will give you vitamin K. See, in case of vitamin K deficiency, because that is again the coagulation disorder. So in case of vitamin K deficiency, what we see, in case of vitamin K deficiency, in case of vitamin K deficiency, the prothrombin time will also be increased. The prothrombin time, APTT, will also be increased. The all will be increased in case of the vitamin K deficiency. Then other things you need to remember, in the hemophilia there is the normal platelet or prothrombin time. Okay, let me write it here only. This is PT means prothrombin time, and that will be the normals, except the APTT, that is the activated partial thromboplastin times. That will be increased. Okay. So now read the question. The intramuscular hematoma examination, we see there is a rise of prothrombin consumption and significant prolongation of the activated partial thromboplastic time. What is the most probable diagnosis? So what is the most probable diagnosis? That is what? Hemophilia. Okay. Okay, so revise everything till now, then we will continue. Okay, revise till now what we discussed. Okay, see. Okay, so let's take the 5 more minutes breaks as you ask today after a long. Or can we start? Okay, how's your study going? Are you practicing the questions? Just I'm muting, unmuting. Wait, you can turn on your microphone. So, are you practicing the questions? Those who want breaks, you can take the break. Others, for those who wants to talk, they can talk.
We
Wait, wait, while my voice
can you hear me, sir?
yeah, now you can hear me.
Oh, okay. Uh, it's going okay. It's there's a lot involved in the studying. Taking the notes. You've been very kind of sharing some of the notes, and we're trying our best, but we're also seeing the benefits day by day, day by day. It's things are sticking in the head for me anyway. It's very, very beneficial doing this every day and doing my own studying. Some of the things are sticking in the head like never before. So I think this is very, very, very. I think this is the best choice I've made in terms of revision, and I think everybody else would say the same, maybe.
Yes, I agree with you 100%.
Just whenever you are free, just try to do the questions on the test center website. Okay,
Yes,
use
trying
the
to do something.
I tell you everything like how you can download the PDF and everything you can download. And if you are not like comfortable doing the questions randomly on the test center website, you can download the PDF and you can just see the questions, or you can search those questions whatever you revise. Like for example, if you studied the rheumatology or you need to revise the rheumatology, so you need to download the PDF. Just go to the click on any test center paper, like for example Ukrainian paper, Russian paper, or translate that paper into in English. And after that, once you done with the rheumatology base, just see all the questions on the rheumatology. Like you will get some keywords about osteoarthritis. Try to search osteoarthritis, all the osteoarthritis questions will come. If you try to search any things like related to the questions, or maybe like you are starting the search cartilage in the like Google Drive. When you open the Google Drive, search there cartilage, so all the rheumatology questions can come. Or the search like carpal tunnel syndromes, if there will be the questions on the carpal tunnel syndromes and all those things on the rheumatology, then you will easily get all those questions. Okay, so this is the tricks that you can use for any others. If you have any PDF or any like I also shared the general PDF paper. So in that also you can search all those questions related to the rheumatology. You need to search the some keywords that can be seen in all the questions. Like the cartilage is there, that can be seen in the osteoarthritis question, that can be seen in the rheumatoid arthritis questions. You see, you need to search the lumbar. When you search the lumbar, all the ankylosing spondylitis questions will come. Because in ankylosing spondylitis, most probably they will give you something lumbar regions is there. And other than that, like for example, if you studied the today, so today you can search the hemorrhage. Once you revise the all the hemorrhage topics, search in the Google Drive hemorrhage. So there will be and all the words of hemorrhage or the in the questions. So all these will come in the maybe it's 5
think I shared one things, the group. Yeah, there is 2005 to 2000. This is the paper. 2005 to 2021 questions. So in these things you can share, like when you will click on the share button, so in that things you can see like hemorrhage. If you will put the, if you will search the hemorrhage, so when you will search the hemorrhage, there are many like 60, 60, 82 is there. So when you will click on the hemorrhage, see the first question is already there, the hemorrhage in the ventricles of the brain, subarachnoid hemorrhage, periventricular hemorrhage, subdural hemorrhage. I hope you will be able to watch, see this. See, this will be the mirror image. See, I will share you like on the group. Wait. Everyone try to do this like this only. Okay, like this type. You need to search here the hemorrhage. You can see there is a 6 to 18 thing is there, 6 to 82, and here you can see the hemorrhage, hemorrhage, hemorrhage. All those questions will become.
Sorry, I can't see anything, sir.
No, now you will see in the.
Oh, you sent it. You sent. Okay, okay, okay.
Okay, so like this type of the questions, like you can see there's a periventricular hemorrhage. So this question again, the same question is there. Morose and Babinski reflex is there. So that's why we'll be having the subarachnoid hemorrhage. Like this type of the questions, many questions you will get. Many questions like similar questions you will be, it will be there. There is a one more questions that is not related to today. I hope you all get this what I wanted to say. There is one more question about the cerebral hemorrhage and the brain hemorrhage. So it will be beneficial. Okay, you don't have this PDF. But I'm sending all the PDF and so these are the questions like the Croak 2 2005 2021 general medicine. Okay, so time is over. So let's start. Now I'm connecting my microphone. So my voice, your voice would not be audible to me. Okay, so just
Okay. Okay, so the next questions. Hello. Okay, so the next one is what we having. So this is what APT, activated partial thromboplastin time, and all those things will be there. That is okay. So the hemophilia in vitamin K deficiency, if you having the one more question related to this, in which you will get the options of the vitamin K deficiency also. So if the vitamin K deficiency is there is increase the prothrombin time, along with that there is increase the APTT will be there. Okay. Okay, now just don't focus on the group, focus here. Question number 74 we already did, then the diphtheria we already did, then now come back to the question number. See, yesterday I told you one thing here. dark green liquid stools. So the dark green, if there is, you will getting the stool, so that can be seen in the salmonellosis. Also it can be seen in the shigellosis. Okay, but in the salmonellosis, I told you yesterday, there is a milk with there. Okay, chicken and the milk, that's why they give the answer is the salmonellosis. There is a history of unboiled milk. The stool is liquid and the dark green, they can be seen in the both like salmonellosis as well as shigellosis. So read that clearly. And in the salmonellosis, I told you other characteristics features also, that there is a small intestine is affected, large intestines. Other history they will can also give you, but make sure that don't, if your stool is liquid dark greens, they can be the salmonellosis as well as they can be the shigellosis as well. Okay. Then the next questions. Okay, come back to that question only. So Henox colon disease we already studied, and A by fibrogenemia, and the hemorrhagic disease of the neonates, that is like the anemia type. And what is the Verlhof disease? The Verlhof disease is the ITP, that is immunothrombocytic purpura. I think we missed on that day. Let's discuss where. Did we discuss the hemorrhage before or also? I think no, we did not discuss. See, where we discussed the Henox colon purpura, so there we can also discuss the ITP. So remember the one more important here, that is the ITP. ITP is the immune thrombocytopenic purpura. Immune thrombocytopenic purpura. See, in case of immune thrombocytopenic purpura, this is condition is also known as the Verlhof disease. This is also known as the Verlhof disease. So remember, like if the patient having the immune thrombocytopenic purpura is there, that is also known as the Verlhof disease. So there is, in these conditions, whenever you are discussing about the ITP, so you need to rule out the other secondary causes of the chronic ITP. So when you discuss the ITP, as the name is saying, immune thrombocytopenic purpura. So immune thrombocytopenia is there. So of course there will be the decrease in platelets. Do you remember? Then in Henox colon purpura, where we discussed the Henox colon purpura, I told you there will be the normal level of the platelets will be there in Henox colon purpura. But immune thrombocytopenic purpura, there will be the decrease in what platelets will be there. So ITP, it is considered like the primary or it can be the secondary. See, it includes the mainly the most common is what, that is the primary ATP, and in the primary ATP it is the immune mediated destruction. There will be the immune mediated destructions of platelets. The immune mediated destruction of platelets will be there. Then also remember, there will be the inhibition of platelet release from megakaryocytes. The inhibition of the platelet release from the megakaryocyte. What does that mean? This is the immune mediated, because okay, that is the immune mediated, that understand inhibition of the platelet that release from the megakaryocyte. Megakaryocyte, it is the like megaloblastic cells, we can say. This is the cell that present in the bone marrow. So there will be the platelets will be inhibited. The platelet will be not formed from the bone marrow itself. So that's why there will be the decrease in what platelets number. The decrease in the platelet, and the platelets become less than 20,000 in number. Then after that, we can see that this primary ITP, this is common in the children and adult. This is common in the children and adult. Other than that, you can remember one keyword here, that is there is the mucocutaneous bleedings. Mucocutaneous bleeding means There very tiny bleedings will be seen. See, platelets have very important role in our body. Like for example, if any patient having the dengue also, the patient having the dengue also, these patients, there is a one of my there is a one person in my village area, and he got the dengue. He got the severe dengue at that time, and he having the decrease in the platelets severely, and he got the death due to bleeding, due to lots of bleedings. Okay, so he got in the which shock? Hypovolemic shock, due to blood loss. So of course the platelet, they help in the coagulations, and they will help in the clotting of the blood. If the platelets will not be there, there will be the major bleeding will be there, or blood loss will be there. And here you can see there is a mucocutaneous bleeding will be there. The peripheral smear, other normal peripheral smears will be seen. Normal peripheral. What is the peripheral smear? RBC, WBC. This is the what? Peripheral smear. We also do for the platelets, we do the direct Coombs test. We do the direct Coombs test. And remember the direct Coombs test for the ITP, that will be the negative. Along with that, as we see, there is inhibition of the platelet released from the megakaryocytes. So remember, there will be the giant megakaryocyte. There will be the giant megakaryocyte in marrow. There will be the giant megakaryocyte in marrow. And also remember, they having the antibodies also, that also can be the ask. So they having the GP2B 3A antibody. Okay, so that you need to remember. There is a mucocutaneous bleeding, normal peripheral smear, direct Coombs test will be negative, and there is a giant megakaryocytes in the marrow. Okay. So that this is the major thing that you need to remember about the ITP is what, that there is a decrease in the platelets number. And also the one more reasons, there is a presence of like the antibody that we will see against the destructions of the there is a platelets membrane. We are having the platelet membrane protein, that is the glycoprotein. So sometimes the immune mediated destructions of the platelets, or mainly we can say the glycoprotein membranes. Glycoprotein, but that you should not remember in the details, but remember there is a immune destruction of the platelets, due to which there is a decrease in the platelets number there. Okay, so this was about, so that is the Werlof's disease also. Now come back to the next questions. 81. A full-term infant is 3 days old. On the different part of the skin, there are the erythema, erosive spots, cracks, area of epidermal peeling. See, if any peeling is there, it means, see, if my epidermis or any lesions on my skin, if I am putting the lateral pressure on my rashes or that lesions, so that will be peeled off. So this is what we call the Nikolsky symptoms. That is called the Nikolsky sign. That we call the Nikolsky sign. The area of epidermis is peeling. The infant has the scalded skin syndromes. They already given the patient. The infant has the scalded skin syndrome. Nikolsky symptoms is positive, or Nikolsky sign is positive. Grade condition of the infant is grave. Okay, anxiety, hypertension, febrile temperature evident. They already give us the main feature. There is area of epidermis, peeling is there, scalded skin syndromes, and Nikolsky symptoms is positive. So we can directly say this is the exfoliative condition. This is the exfoliative conditions. Okay, so let's come back to our exfoliative dermatitis. So there are some toxins, like see, we having the also called this condition, let me write it here. There is a epidermolytic toxins. The epidermolytic toxins, or we can say exfoliatants. See, these epidermolytic toxins, these are responsible for epidermolytic toxins. These are responsible for the staphylo-scalded skin syndromes. This staphylo-scalded skin syndromes, or we can call it as the Ritter's disease. We can call it the Ritter's disease. They are also responsible for the bullous impetigo. They are also responsible for the impetigo. And impetigo, I told you one things to remember. Impetigo, there is one very good keyword for the impetigo. What was that? Impetigo. Is my voice fading out? Impetigo. What was the keywords that I told you? Okay, if it is the impetigo, this type of the appearance will be seen. In case of the impetigo, what type of appearance will be seen? No one remember? Honey crushed appearance. What was that? Honey crushed appearance. Honey crushed appearance. That I told you to remember these things. So the honey crushed appearance that we seen in case of the impetigo. Honey crushed appearance will be seen in impetigo. Okay, there are some lesions that we will discuss like after the class, like what are the macules, papules. So today only we will discuss. Okay. See, after that, these epidermolytic toxins, remember, this can be seen in the neonates and young infants. They are seen in the mainly in the neonates and young infants. Okay. What is the, this is the these are toxins that are responsible for the SSR, the Ritter's disease or the bullous impetigo. So one conditions we can say here, that is the exfoliatins. So that can cause the exfoliative dermatitis. That can cause the exfoliative dermatitis. Now you understand from by seeing this type of the questions like atopic dermatitis or these type of the questions. Now you can see that there are the note four topics there. We have the note therapy, OBG, surgery, and note these four only. We having the dermatology also included. That's why I was saying in therapy it includes everything. That's why they put not just internal medicine. In therapy, the major subject is internal medicine, and all others related to subjects will be there, like the dermatology, anesthesia, radiology. Radiology, they will not give the images most probably, and we having like the dermatology, all these things will be there. Exfoliative dermatitis, this is the diffuse severe inflammations. There will be the diffuse, like the whole body or the whole epidermis will be involved. So there is a diffuse severe inflammations will be there. Then there, what we will see in this condition, there will be the extreme redness of the skins. We will see there is extreme redness of skin will be seen. The extreme redness of the skins will be seen. Other than that, we see the scalings in the skins. We will see the crusting lesions. We see the crusting lesions will be seen. And the skin will be thick. The skin will be thick in this condition. There is a thick skin will be seen. There will be the itching. There will be the itching will be there. Along with that, we see there is a swollen lymph node will be there. The swollen lymph node will be there, and there will be the loss of fluids and proteins. Loss through damaged skin. So of course these patients will be dehydrated through the damaged skin. So that's why these patients will be the dehydration. These patients will be having the dehydration problems and the protein deficiency as well. So, okay, I'm repeating it again. Exfoliative dermatitis, there will be the diffuse inflammations, and this is the severe inflammation will be seen. There is extreme redness of the skin will be seen in this condition. in this condition, there is a scaling will be there, crusting lesions will be there, the thick skin will be there, itching, swollen lymph node will be there, and the loss of the fluid or the protein loss through the damaged skin, that the dehydration and the protein deficiency will be seen. Okay. After that, now Nikolsky symptoms is there. So there is one more thing, that is Nikolsky positive. So that is what Pemphigus vulgaris. That is what Pemphigus vulgaris. So there are the two things about the Pemphigus group. The Pemphigus group, there are the two things. When we having the Pemphigus vulgaris, and another we will be having, that is bullous pemphigoids. When we talk about the Pemphigus, so we having the so write this table: Pemphigus vulgaris, or we can say bullous pemphigoids. Bullous pemphigoid. See, Pemphigus vulgaris, this is common in the age 30 to 40 years. This is common in the age 30 to 40 years. And this is common in the age 70 to the 80 years. This is common in the 17 to 30 years. Okay, the Pemphigus vulgaris and the bullous pemphigoids. 30 to 70 years. They having the antibodies. They having the antibodies. Which antibodies they having? They having the anti-desmoglin. They having the anti-desmoglin antibody. The anti-desmoglin antibody, they having antibody, that is anti-hemidesmosomes. Anti-hemidesmosome antibody will be there. There will be the, when we do the immunofluorescence, there is a techniques that we call the immunofluorescence, where we use the fluorescence dye. And when we do the immunofluorescence techniques, we see there will be the fish net pattern will be seen. There what we will see, fish net pattern will be seen, and here in bullous pemphigoids we see there is a linear Sorelli's patterns, or you can say, remember just linear pattern, because till in the croc one you will get just linear pattern. You need to remember there is the fish pattern that is seen in the bullous fish net pattern that is seen in the Pemphigus vulgaris, and linear pattern will be seen in the bullous pemphigoid. Okay. What about the bullae? All these things, so I will tell you what are these, the bullae and all these bulla, macules, papules, we will discuss. So here you will see the bullae, they are the thin and fragile. They are the thin and fragile, and this is what in bullous pemphigoid, these are deep and tense will be there. Then we having the mouth involved. Is mouth involved? Yes, the mouth is involved in Pemphigus vulgaris, but here no mouth is involved. Nikolsky sign. Nikolsky signs. The Nikolsky sign, it is positive in case of the Pemphigus vulgaris. It is negative in the bullous pemphigoids. What are the symptoms? The symptoms here we can see, this is the painful conditions. What we can see, the painful conditions, and this is what, that is the pruritic conditions. That is the pruritic conditions. Severity, life threatening. We are having the life threatening will be there, and then it will be the results by all. So that you need to remember. We are having 32. There is a 30 to 40 years, 70 to 80 years. Then we having the antibody, that is anti-desmoglin, or we having the anti-hemidesmosomes. Then there is immunofluorescence, that is the fish net patterns, and we have the linear pattern will be there. Then there is a bullae, that is the thin and fragile. Bullae, thin and fragile. Here there is a deep and tense bullae will be there. Mouth involved, yes, there is involvement of the mouth. In case of the vulgaris, there is a no involvement. Nikolsky sign, this is the positive, and there the Nikolsky sign is negative. The symptoms we see, Nikolsky sign, the positive and the negative. The symptoms we see is the painful conditions, and we will be having the pruritic conditions. Then the severity we see there is a life threatening, and it will be resolved. So that you can understand. So we have the two conditions. We have the Pemphigus vulgaris, and then we having the bullous pemphigoids. Sorry for wrong table, but that you need to understand this one, not these things. Pemphigus vulgaris 30 to 40 years, 70 to years. The main thing you need to remember in these conditions, see, if you are getting these things, like there is a Nikolsky sign is positive and the Nikolsky sign is negative. Is positive in case of Pemphigus vulgaris, and it is the negative in what? It is the negative in case of the bullous pemphigoids. Okay, this you should remember very well. And Nikolsky sign, I already told you what is the Nikolsky sign. See, if this is my hand, okay, this is my hand. In my hand, having some like bullae is there, okay, like this type of the findings is there. If I am putting the lateral pressures, so this will be peeled off. Skin will be peeled off. This is called the Nikolsky sign. So when lateral pressures applied on border, when the lateral pressures will applied on the border of intact blisters, it will result in the peeling of the epidermis, and this is called the Nikolsky signs and the positive Nikolsky signs. Okay, so that you need to remember for this condition. I hope this is done. So if you are getting the SSS also, there is a Nikolsky sign positive. There is a, along with that we can see exfoliative toxins, or the exfoliative toxins we studied, that there is exfoliative toxins, or we can say this is what exotoxin as well. We can call also this as the simple terms exotoxin. This is what exotoxin will be theirs, and Nikolsky sign will be positives. Nikolsky sign will be positive. Nikolsky sign will be positives. So that you need to remember. So here you can see the area of the epidermis, scalded skin syndromes. Of course, that will be the what are the most probable diagnosis we see? That is the exfoliative, due to exfoliative toxin or the exotoxins. So that is the exfoliative dermatitis. Okay, we studied that there is a cracks will be there in the skins. Along with that, there is a redness we will discuss. See, there is a extreme redness of the skin. We can call this erythema. The crusting lesions. Here we can see there is the cracks. So that cracks means what? We can say that this is the cracks. Okay. So this is the exfoliative dermatitis. Then one more thing I was telling you today. Okay. Okay, let's come back to the pulmonology topics. See, for the pulmonology topics, like according to the Croak 2, I was very also confused with this terminology. Because like for the Croak it is like little bit different. There is a wooden resonance, there is a tympanic resonance, all these things is there. So but for pulmonology you need to remember these or 3 or 4 findings. See, if you are getting any questions on the pneumonia, so for the pneumonia you need to remember there will be the dullness will be there. What is the meaning of the dullness? I told you that any fluid or anything is there, so there will be the weak breathing. Will be there. In case of the tracheitis, in case of the tracheitis is there. So in case of the tracheitis, remember there will be the, you see the resonance is there. You will get all these keywords you will see in the questions. There is a resonance is there, leukopenia will be there, and dry cough will be seen. And the dry cough will be seen. Bronchitis. These are the some keywords for the Croc 2 questions. All these questions will be solved from here. The bronchitis, you see there is a resonance. Along with that, you see the sputum cough, cough with sputum. So that is seen in bronchitis. The one is what? Obstructive. So in obstructive, we studied that there is a wheezing problem like asthma and all these things. We see there is a wheezing things will be there. And in the bronchiolitis, see some we already discussed these things in details. But I am telling you some other keywords that is help you to clear the questions. The resonance, and it is the mostly common in the children less than 3 years old. Okay, this was on my notes. I don't know from where I wrote this, but this was on my notes. Like I wrote somewhere on my notes, so I was just checking everything and I got this table. So this is like very beneficial table. So in these questions you can see that there is a dullness is there, tracheitis, resonance, leukopenia, dry cough, bronchitis, resonance, there is sputum cough is there, and all these findings. Obstructive, there is a wheezing will be there. So all these things you can see. Okay, and all those questions you can easily identify. The bronchiolitis we studied the inflammations or the swelling of the bronchioles. Bronchitis we studied there is a inflammation or the swelling of the bronchioles. Okay, then we can see that if the when we see the band, where we see the band box resonance, there is one more term is there, that is the band box resonance. If you are getting the band box resonance, so the band box resonance, remember there will be band box resonance means no dullness is there. Band box resonance means, see, resonance means there is a no dullness. So band box resonance is the same, there is a no dullness will be there, and if the no dullness, there will be the no pneumonia. And also remember, like bronchiolitis, it will affect the children's like under the age of the 3 years old, and that will be seen. And the bronchitis, you also see the resonance, but along with that you will see the sputum cough will be there. Okay, and acute tracheitis, I told you that there is a resonance will be there, leukopenia will be there, and the dry cough will be there. And in the tracheitis, this is a thing again seen in like the mainly in the children's tracheitis. This is again mainly seen in the, it is mainly seen in children. And in the tracheitis we don't see wheezing, so there is a no wheezing will be there. So no wheezing means no obstruction is there. Okay. So here you can see there is a temperature rise up to 38 degrees Celsius, dry superfluous, appetite loss. Palpation didn't reveal any changes over her lungs. Percussion sound a wooden resonance. The wooden resonance is there, and the puerile breathing is there. There is a leukopenia we studied, that if wooden resonance is there, leukopenia is there, that is just simply write it acute simple tracheitis. The tracheitis is what? The tracheitis means the inflammations of the trachea. Okay, that you need to remember. The tracheitis is what? That is the like the inflammations of the tracheal regions, and it can be due to bacterials, it can be due to any fungal infections. Along with that we will see there is some resonance will be there, means no dullness will be there. And along with that in the case of the like the tracheitis, you need to remember there were one more things. Sometimes you can get the problems like the striders. Okay, and along with that you will see there is fever as well, because it can be involved the bacterial as well as the fungal infections. the bacterial as well as the fungal infections. These things you can remember. Okay. The acute say normally in the other exams they ask you about the bronchitis, obstructive bronchitis, bronchial asthma, COPD, but in the croak they ask you the tracheitis. That is rarely happens. Because bacterial are the normally the bacteria they when go to the lung they will involve the mainly the lungs or the respiratory pathway. The trachea is most commonly affected because of the peristaltic and all those movements. So that's the rare findings. But if the wooden resonance, leukopenia is there, why the leukopenia and lymphocytosis is there, along with that fever will be there, and there will be the cough, like the sputum cough will be there. So that is the things always remember, that is the acute simple tracheitis. And all these findings it will be easy to make all the questions about the tracheitis, bronchitis, obstructive bronchiolitis, bandbox resonance. Anemia we will discuss later, because that is the everything about the anemia we will discuss on together. This topic is also the big topic, but I think we should continue this. So this will be the last. Okay, do. Okay, let's come and we will finish this. A 12-year-old girl took 2 pills of aspirin. 4 hours later, the body temperature raised up to so you are seeing that there is 2 pills of the aspirin, and 4 hours later, body temperature raised up to 39. She complained of general endosphagenia, dizziness, sudden rash in the form of the red spots, and the blisters is there. Objectively, the skin regions resembles of the second-degree burns. And here and there with the erosive surface or epidermis peeling. Nikolsky's symptoms is positive. What is the most probable diagnosis? So this condition we seen in the acute epidermal necrolysis. So see, there was the conditions we having the 3 type of this type similar conditions. First is the erythema that resembles, you need to remember, that is the second degree burns. So there is 3 conditions, like we have the erythema multiforme majors, Stevens-Johnson syndromes, and there is one more condition, that is the toxic epidermal necrolysis. So these type of the condition, firstly we consider it into the one thing, that is the earlier we called it the erythema multiforme, and together they will form a spectrums. After that there is like it is related to the self-limiting cytotoxic dermatitis, and due to cell-mediated hypersensitivity. So after that it will be like resolves and is separated into the 3 parts. And what was the 3 parts? One, we having the erythema multiforme major, Stevens-Johnson syndromes, and toxic epidermal necrolysis. So we will discuss these things one by one. Okay, just give me a second. Okay. So let's make a table again. There is erythema multiforme major, then we having the Stevens Johnson syndrome, and we having the toxic epidermal necrolysis. See, if we having the less than 10% body surface area is affected, if we having the less than 10% body surface area, the less than 10% body surface area is affected. So that is conditions we see in case of the erythema multiforme major. Along with that, here also we having the less than 10% body surface area that is involved. But in case of the toxic epidermal necrolysis, there will be the more than 30% will be seen. See, all in these conditions we having this, like this type of the conditions will be associated with the burning infections. So there less than 10% burn, less than 10% burn, and more than 10% burning area. What is the cause of this condition? The erythema multiforme, mainly this is caused by the herpes simplex virus. They is mainly caused by the herpes simplex virus. Please be focused here, because this type of the questions will confuse you very much, है ना? Because there is less than 10%, you will see, okay, all these three options can be there. So read it very precisely. In case of the Stevens-Johnson syndromes, mainly the cause is the drug induced. That is the drug induced cause. Drug induced, like for example, we having the cephalosporin, sulfur drugs, and allopurinols. ALP, that is allopurinols, that we use as the xanthine inhibitor drugs used for the uric acid stones or the uric acid in case of the uric acid gout conditions. Okay, drug induced like cephalosporins. Other things we include that in this condition, that is this toxic epidermal necrolysis, again this is the same, that is the drug induced. The same, like we have the cephalosporin, the sulfur drugs, and the allopurinols. Okay, after that you can see that in case of erythema multiforme, you are having some associated symptoms, and these associated symptoms you need to remember, like we having this erythema multiforme, we having the less fever and other constitutional symptoms. But in case of like we having the Stevens-Johnson syndromes, we having the fever, malaise, and headache. The fever, malaise, or headache. The same will be here. I'm repeating, and write it here: fever, malaise, or headache. Fever, malaise, and headache will be there. And also there will be the severe mucosal involvement. The severe mucosal involvement will be there. Here also we see there is a severe mucosal involvement. Severe mucosal involvement will be there. Okay. And here we will see the milder mucosal lesions. Milder mucosal lesions. After that, you can remember there were like what type of the lesions we seen in case of the in all these conditions. So the lesions that we seen in all these conditions, there we having the erythematous, means we have the radish, the erythematous. Then we having the erythematous papules is there. Along with that, the target lesions, that is important. We having the target lesions will be there. They having the raised atypical targets. The raised atypical targets will be there. Then in case of Stevens-Johnson syndromes, अरे हो ना यहाँ पे सभी चले गए. हाँ, okay. Hyperesthesia scaly. Okay, I'm not seeing the message. The vesicles on, there is a vesicles on erythematous. The vesicles on the erythematous base. Erosions purpuric macules is there, purpuric macules will be there. Okay, and remember that this Stevens-Johnson syndromes, this is the Nikolsky sign positive. This is the Nikolsky sign positive. This is the Nikolsky sign positive. Then in case of the toxic epidermal necrolysis, they having the diffused generalized epidermal detachment. They have the diffuse generalized epidermal detachment. That is the very, very important keywords for this toxic epidermal necrolysis. See, there can be the spores here, there can be the without spores, but that you need to not to remember here. Just remember the diffuse generalized epidermal detachment, and also we will having the Nikolsky sign positive. The Nikolsky sign will be positive in this both condition, erythemus, scalded skull syndromes and the toxic epidermal necrolysis. Okay. After that, if we talk about the distributions, they have the distributed on the, they are the distributions. The distribution, they are mainly present on the distal extremities. Then they are present on the, they have the variable distributions. They having the variable distribution. They also having the, variable extensive distributions. Variable extensive distributions. The next point is again very important. See, when we talk about the histopathology, so in case of the histopathology, there will be the interface dermatitis. You can see here, there will be the interface dermatitis. Histopathology is not important for the erythema multiforme, but here in this condition we can see, you will see the dermo-epidermal separation. Here you will see the dermo-epidermal separations will be there. The epidermal separations will be there, and here you will see epidermal necrosis will be there. Epidermal necrosis will be there. Very, very important keyword findings. Okay, the recurrence, if we talk about the recurrence rate, it is common in case of the erythema multiforme. This is uncommon, not so common in case of the both those conditions. Okay, that you need to remember about this thing. See, the main things you need to understand that this one is important. Less than 10%, more than 10%. Toxic epidermal necrolysis, we also call is the Lally, that is Lal syndrome. We also called it Lal syndrome, Swaha. Erythema multiforme measures, Stevens-Johnson syndrome and toxic epidermal necrolysis. Less than 10% body surface area, erythema multiforme. Stevens-Johnson's less than 10%. Toxic epidermal necrolysis more than 10 or 30%. Now see the questions and let's see. Sudden rash in the form of the red spot and the blisters. Objectively, there is skin lesions resembles of the second degree burns, and there is a erosive surface or epidermis peeling is there. So we call this condition as the acute epidermal necrolysis, or we can also call is the TEN, toxic epidermal necrolysis. Okay, so what is that? Why we call it is not at the moment? This is the drug induced. This is the drug induced. This one will be the drug induced conditions will be there. Okay, so that you need to remember, because it is like the patient. See, I told you already that aspirin, it is contraindicated in the children's, but here as children is taking, so that the drug induced that can cause what? Here what it causing? It is causing the, yes, it is causing the necrolysis conditions. Okay, so here you can see that, see, there is a one thing we discussed, erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis. If less than 10%, TBSA, यानी कि total body surface area is involved, that we call erythema multiforme. If less than 10% body surface area is involved, then erythema multiforme as well as the Stevens-Johnson syndromes. But if more than 30% area, is involved, we call this as the toxic epidermal necrolysis. Okay. And also remember one more thing about the toxic epidermal necrolysis. This is the most common or the associated with the HIV patients. They both having the positive Nikolsky sign. In erythema multiforme, we see main thing what we discussed, target lesions. The target lesions, that is the important features of the erythema multiforme. Target lesions will be seen in erythema multiforme. So this is the conditions that is here we are to having the acute epidermal necrolysis. Pemphigus vulgaris that we already discussed. What was that? There is a rare chronic blisterings, that is the most common form of the pemphigus. Blister formations will be there, and that will because the Nikolsky sign positive will be there. When you putting the lateral pressures, so that will be epidermis will be peeled off. Here we seeing the second degree burns along with the drug induced conditions. So that's why we having this is the acute epidermal necrolysis. We can see epidermis peeling. So that's why Nikolsky sign is positive. I hope this is clear. Okay. Okay, so now you wanted to discuss about, just give me 5 minutes or I will discuss, or we can discuss it tomorrow. It's up to you. Five to 10 minutes we'll discuss like macules, papules, or you want to just finish, then we can finish, otherwise we can continue if you are not tired. What you say? Write me here. Tomorrow, okay. What about others? Tomorrow, okay. Today. Samarki Mishra Jigari is today. Okay, so we have 12. Okay, oh sorry. Okay, so we are on the tomorrow. We started yesterday. Now its time is 12 o'clock. So it's 12:01. Okay, so let's continue. So I am following you. Now I have the times. We started yesterday, so we have the already tomorrow. So let's continue. See, we have the lesions. That is like we have the macules. So when we call it macules, the macules, and there is one thing that is the patch. If size of the lesion is less than 1 centimeter, we call it as the macules. The size of the patch is more than 1 centimeter, that we call it as the patch. Then we having the first, this is the second, then third we having the, there is one condition that is the papules, and the papules is less than 1 centimeter. The fourth is what? The plaques. And the plaque size will be more than 1 centimeter. The fifth is what? That is the nodules. So they are the like similar things, papules, plaque, the nodules, they will be more than 1 centimeter plus the depth will be there. So that is the nodules. There is two similar other things, that is the bulla. So bulla, when we called it when less than 1 centimeter blisters formations, and the seventh we called it vesicles. When we called it the lesion as the blisters as the vesicles, when it will be less than 1 centimeter. Then other terminology is what? Pustule and abscess. See, what is the difference between the pus, that is pustule, and the difference between the abscess? The pustule is what? That is the small, and abscess is what? That will be the large and deeper. There is one other findings, that is the petechiae, that is 1 to 2 mm. Purpura, we studied that there is a palpable purpura. What is the size of the palpable purpura? That will be more than 3 mm. There is one more condition, that is ecchymosis. So that is 1 to 2 centimeter. 13 we call it, one thing is the wheal. We have the, see in the wheal we having the central pallor. The central pallor is there, and there is a rim of peripheral. The rim of peripheral edema is there. Rim of the peripheral edema will be there, and this wheel type of the lesion is seen in case of the urticaria. Seen in case of the urticaria. Then we have the scaly lesions. The scale lesions that is seen in case of the two conditions. We have the psoriasis, and there is one more conditions. I think we have the questions also on this, seborrheic dermatitis. Seborrheic dermatitis. Then the seborrheic dermatitis, there is a like we have the involvement of the sebum, like the involvement of the macules or this all these things. That is the seborrheic dermatitis. We will discuss after it. Okay, okay. No, we will discuss it tomorrow. Just this one. Crust, we have the dried exudate. The dried exudate on skin surface. The dried exudate on the skin surface, we called it as the crustings. So it can be the like the pus, it can be the blood, or it can be the serum. So this is the like the scale, and after that we having the crust. There is also the one more conditions that are erosion. That all these terminology is important. There is a one thing that is the erosion. The erosion is, remember, this is the focal and total loss of epidermis. The focal and the total loss of epidermis. 17 we having the ulcer. See, if when we having the ulcer, there will be the loss of epidermis. There will be the loss of epidermis plus partial and total loss of dermis. The partial and the total loss of dermis. What is the fissures? Fissure. What is the fissure? Fissure means there is a linear deep cleft in skin. The linear deep cleft in the skin is we called it the fissures. What is the excoriation? What is the excoriation? See, excoriation is what? These are the scratch marks. These are scratch marks, or they have the linear punctate skin lesions. Everyone, you all aware about what are the scratch marks, है ना? देखो कैसे गुदगुदी मच गई पूरे शरीर में तुम्हारे. That is 20 is what? Lichenifications. 20 is what? Lichenifications. The lichenifications is what? That is due to, this is due to chronic itching. This is the chronic itching. And in the lichenifications, what we see, there is a hyperpigmentation. There will be the hyperpigmentation. There will be the thick skin. There will be the thick skin, exaggerated skin markings. 21, we are having the atrophy. In atrophy, if there will be the wrinkled appearance. There is a wrinkled appearance, like the atrophy of the brains. We studied. I hope every one of you remember one picture of the atrophy of the brain is there, that we can see when the brain will be the atrophied, the brain size will be reduced. After that A, after that B, that is burrow, fissure, burrow. If you are getting the burrow, so there is a wavy serpiginous tunnel in skin. So this burrow seen in scabies. This burrow is seen in the scabies. If you know what is the burrow, like if in the question they will give you wavy serpiginous tunnel, you can easily understand, okay, maybe they are talking about the burrow. There is one more things, A, B, C, that is comedones. 2 minutes रुक जा भाई. Comedones. Comedones is what? That is the dilated Comedones is what? That is the dilated. The comedones is the dilated pilosebaceous. What is the pilo? Pilo means hair. Pilosebaceous unit, and that will be the like plugged by sebum. Like if there is a dilated, if you have the hair, this is the dilated hair, and around the hair we can see there is a sebum part. Around the sebum we can see the sebum. So that is the plugged by sebum. Plugged by the sebum and keratin. And can you tell me that these conditions can seen in which conditions? This is seen in acne. This is seen in acne vulgaris. Seen in acne vulgaris. Acne vulgaris. Okay, now one more lesion, that is the target lesions. Target lesion कुछ इस तरीके से होता है. Target lesions. The target lesions you will tell me. Target lesions. This is the like the target lesions. The target lesions you need to write it by yourselves, or you need to write in the comment. Target lesions seen in which conditions? Target lesion seen in which condition? Target lesion seen in which condition? Target lesion seen in which condition? Just we studied today. बताओ. अच्छा, I will give you hint. There is a less than 10% body surface area is including. Which lesions was the erythema? Write the full name. Erythema multiforme. So that is the correct. So do you want to see the images of all these papules, papules, or all those things, macules, bullas? Yes. Okay, Sui. So yes. So this is your homework. Okay. So you will find that first 10 images, like from the macules to the ecchymosis, from the macules till the vesicles. You will see all the images on the Google, and you will share in the group. Anyone who wants to see the images? 7, 8 once more. Okay. Mani Dheeraj, you will tell, you will share the video, the picture of till point number 10 till point number 16. You will share the images in the group. Anyone? I'm saying is 7, 8 once more. Yes. 7, 8. 7 vesicles less than 1 centimeter. Pustules, that is the smaller. The pustule or abscess. See, where I put the gap, it means there is like this type of the similar. They are the similar. They have the difference in the size. These are like the similars, but they have the difference in the size. These are again the similars. Okay. Anyone who wants to see the images other than that, other than Soy or Mani Dheeraj? Okay, who didn't give any reply today? Let's see their questions. Pragyana Patra, you have the internet issues today, so you will be having homework. You will share the images of ulcers, fissures, excoriations, like from the 16 point till the 24 points. Okay. Hamida Jami has left the meetings. Okay, I will not do the homework. I'm going. Bye. Okay, that you need to do. So yes, you need to share the till 7 images till 8 till the pustules and abscess. After that, Mani Dheeraj, this is your second homework till the 16, and after that, Pragyana, you will share all the images. Hope you all get it. Okay. I will be waiting till tomorrow. ठीक है, whenever you just now relax and after that you search all those, what are the macules, whatever is the patch, papules, plaques, all these will be fine. Okay, Pragyana.
Now I'm correcting. Okay, so take care of yourself and just keep grinding yourself. Hmm. We have just 2 months left, so just keep working hard and keep studying hard. Okay, so see you tomorrow. Tomorrow also we will having the class, and we will try to finish the pediatrics as soon as possible. Okay, so bye bye, good night, Hare Krishna, Radhe Radhe, goodbye, bye bye.